Hello and welcome to the weekly Independent Sage briefing. I'm Hannah Critchlow, neuroscientist, author and broadcaster. Now, last week, Independent Sage discussed the importance of ventilation, a crucial mitigation measure in curbing the spread of coronavirus. Making spaces safe should be a public health priority, and as well as ventilation, there are several other public health measures which could be implemented. They'll be discussed by Independent Sage today. So, for example, could a simple colour-coded scores on doors system be rolled out so that we can make use of indoor spaces safely? Would you want to be aware of any risks before entering a specific room? And could this information help to tweak our behaviours on a site-by-site basis and so reduce exposure? Here to join us in the discussion is Tracy Edwards, Trade Union Officer at Public and Commercial Services Union. There's also Janet Newsham, Chair of the UK Hazards Campaign and Coordinator of the Greater Manchester Hazard Centre. And we're joined by Dr. Iarla Hughes from the initiative Fresh Air Wales. But before we launch into this discussion, we're going to go to Professor Christina Pargle, who will give us an update on the latest figures. Over to you, Professor Pargle.
Thank you. Right, so I'm going to try and not spend too long so that we've got time for the ventilation discussion, which I think will be super interesting. But I am going to quickly cover vaccinations, cases, hospitalizations and death, then look at schools and children and long COVID, because there's been new information that's come out this week, and then just finish with 2 slides on the international picture. So vaccination data. This is just vaccine coverage by age for England up to the 6th of October. And really what I want to highlight here is that we have now started the 12 to 15-year-old vaccination programme, but it's going quite slowly. So far, we're at about 10 or 11% of 12 to 15-year-olds have been vaccinated. And comparing it to when the rollout started for 16 to 17-year-olds in August, you can see that this was much quicker, a much steeper increase than what we're seeing so far in 12 to 15-year-olds, which in England is being rolled out exclusively through schools. Now in Scotland, this is just a bar chart of first dose coverage for Scotland by age to the 6th of October. They are delivering their 12 to 15-year-old vaccines through things like walking clinics. You can make an appointment, and I think they're also going to do it via schools. So you can see that they have now vaccinated 30% of their 12 to 15-year-olds. So if you look at the equivalent levels in England, you can see that actually England is quite far behind Scotland for 12 to 15-year-olds, but also for 16 to 17-year-olds, whereas for other adults, it's much more on a par. Moving to boosters, which we now have data on for the first week, and this is what we'll be tracking over the next few months. This is boosters for over 50s in England by age up to 6th of October. So it's only just started, but you can see we have now given about a quarter of the over 80s a booster dose. For these younger age groups, it's probably mostly going to be people who either have extremely vulnerable conditions or who work in the NHS or a care home. And with boosters, the idea is that once you're 6 months out from your second dose, you are qualified for a booster. So when the booster program kind of started at the end of September, we had about 3.5 million people who were eligible in that they'd had their second dose of vaccine by the end of March. So at the moment, we're playing catch up, where ultimately we want to get to a stage where everybody who's eligible gets their dose around the time that 6 months in. So that's also something we'll be tracking over the next few months. So moving on to cases, hospitalizations and deaths. Cases in the UK overall have started they were flat, and then the last couple of days have actually shown quite sharp increases. So we were back over 40,000 UK cases yesterday for the first time since the end of August, beginning of September. All of the kind of demographic breakdowns by age, region, and so on have a kind of 5-day lag. So I don't really know where that increase is. If we look at cases by date of test, which is, as I said, a few days lagged by nation, you can't really see that increase yet, but you can see that no nation is now falling, except possibly Scotland still, but basically the others are flat and possibly going up in Wales. So over the next few days, it should become clearer where those increases are happening. In terms of hospitalizations, everywhere is still falling. This is the number of people in hospital per million people by each nation, kind of flattening off in Wales and England. But I'm hoping that that will keep falling over the next month, and hopefully boosters as well. We should start seeing an impact from boosters on this data. I just wanted to highlight hospitalizations, hospital admissions in England by region, because this has been consistent all summer, and we're still seeing a much higher burden of hospital admission in the northeastern Yorkshire and the northwest, and now the Midlands as well, and the southeast really being by far the least impacted. And as we're moving into winter, this kind of difference, it will make an impact into the care that's delivered. And we need to be aware of the fact that there are big regional differences in the burden on the NHS. And this kind of regional pattern is very consistent with the ONS infection survey of regional estimates, where they also show that cases are highest in the north of England. On deaths, we have seen kind of consistently somewhere between 100 and 200 deaths reported all summer. That is now starting to fall a bit, which is good news. But I think what it's really reflecting is that as we've gone into autumn, we've seen cases in older adults start to fall and cases in children start to go up. And because the risk of death in children is far, far, far lower, we are now starting to see that feeding through to death. So hopefully deaths will carry on declining, at least for the next few weeks, because it's reflecting more cases in older people. So schools and children. Case rates are still really high in 10 to 14-year-olds. So up to the 2nd of October, about 1.5% of all 10 to 14-year-olds tested positive in England, and about 0.5% of 15 to 19-year-olds and 5 to 9-year-olds. Now, this looks like it has peaked, at least for now. The cases have started to come down, which is obviously good news, but still remain extremely high. Cases in their kind of parents' generation are flat at the moment. And so far, we're not seeing it going into the over 60s, which is good news. And we can also see now that the 20 to 29-year-olds who've consistently been really high are actually now among the lowest rates in England. This is the ONS infection survey released today, which shows you a different view. Oh no, this is the wrong slide. Oh, well, I'm not going to linger on this then. I must have deleted the wrong slide from my presentation. But basically what it showed today is that this is from 2 weeks ago. And now the infection rate in school year 7 to 11 is almost 7%. It was 6.9%. So more than twice what it was 2 weeks ago. And in primary school age children, it was up to 2.8%. So we are seeing really consistent and high infections in school children compared to adults. And this has continued. So schools year 12 to 24 and ages 25 to 34 have continued to go really far down. And I think that's a combination of previous infection and vaccination. And also what is in this week. So again, I'm sorry, this is the wrong slide, but the real slide is on Twitter. If you go and look there, is that this has gone up now. So ages 35 to 49 are about 1.5%, almost double than they were 2 weeks ago. So we're seeing that idea that we've got two epidemics, that we're seeing an epidemic in school children going up and their parents, and everyone else is declining. This is having an impact on hospitalizations. So this is hospital admissions for children to the 5th of October. And we can see that, in the last 2 weeks, it has been climbing quite a lot in school age children. And I hope that That doesn't continue, but with the high infections that we're seeing, it's likely to stay high, at least for a bit. Here we go. This is the plot. So this is the latest one. So you saw the one from 2 weeks ago. And so you can see here that primary school age children have carried on going up over the last 2 weeks, but at quite a steady rate. But in secondary school children, we're seeing this really high increase to now almost 7%. And the previous maximum before this wave was in December 2020, when it got to just under 4%. So we really are seeing infections in children that are far higher than they've ever been, about 1 in 14 children testing positive in the week to the 2nd of October. And this is now their parents' generation, which has climbed from a couple of weeks ago. And the other generations you can see here are all under 1% and all flat or going down. Now, I thought this would be interesting. So this is the number of children off school, either because they've had COVID, which is the blue and orange colours, or because they were a contact. And as we remember from the end of last summer term in June and July, there were a massive number of children off school. So by the time we got towards the end of term, over 1 million children were off school, but almost all of them were because they were a contact. Now, we removed the requirement for contacts to isolate, and that has meant that more children are in school. But it has come at a cost, in that although we do have more children in school because of contacts, we are seeing, if you just look at children who either have COVID confirmed or suspected, that has gone up a lot and is higher than it's ever been. So really what's happened is that, yes, more children are in education because we're not doing the bubbles, but more children are now getting COVID than ever before. And we haven't actually put in place any additional protections to prevent that happening, such as ventilation, which we'll be talking about later, and also masks in secondary schools. And on long COVID, the ONS released it releases a report on long COVID every month, and it released its latest one yesterday. And I just want to highlight 2 things from it. So this is the number of people who have self-reported COVID, the people who tested positive with COVID and say that they've had symptoms at least 4 weeks after they were first tested positive. And this goes up to the 5th of September. So they would have had to be tested positive in July or August to report long COVID. And basically what ONS says is that the biggest increase in people reporting long COVID is people who tested positive in the last 8 weeks. And that really represents people who've been affected over the summer. So it went up from 50,000 people a month earlier to 130,000 people at the 5th of September. And that's reflecting this high number of people we infected in July and August. And it kind of just shows that when we were saying that infections have consequences, these are kind of some of the consequences of an increase in long COVID. And if you look at it by age, again, ONS infection survey says by far the biggest increase was in people aged 17 to 24. And if we look at cases in July and August, it's kind of a mix between the blue line, this blue line, and this yellow line. It's exactly the age groups that had the highest burden of COVID. So although most 17 and 24-year-olds will be fine, but although very few of them need hospital, there is a consequence. And we're seeing it right now in these long COVID statistics. And unfortunately, with the continued really high rates of cases that we've had ever since, we should expect this to continue. The other thing that they said is that the people working in the hospitality sector experienced the biggest monthly increase in the prevalence of self-reported long COVID. And I think this actually is really important for the discussion we're going to have, because this is about making workplaces safer and making risky workplaces safer. And we know that hospitality sector is one of the risky places, and the people who work there don't really have a choice about the work environment they go into. And we are seeing that they are experiencing, firstly, high cases of COVID and now long COVID. And just to end on the international picture, this is the number of cases per 100,000 people in the 2 weeks to the 3rd of October in Western Europe and Scandinavia, so kind of similar countries to us. And you can see that we have had by far the highest number of cases. So it's certainly not inevitable that the kind of case numbers that we have been living with for the last few months are inevitable and a consequence of being open. I mean, all these countries have open economies. And it's not, and some of this might be differences in testing and case ascertainment. But if you look at deaths, which is a more unambiguous measure, you can also see that the UK has by far the highest death rates among these countries as well. And that is where I'm going to end.
Thank you, Christina. We're now going to go to Professor Elizabeth Stokoe, who will present us with a new paper from the Independent Sage Behavioural Group. And then we're going to go to Professor Stephen Reicher, who will introduce our special guests. But first, Professor Stokoe, over to you.
Liz, you're on mute.
Terrible. Okay. I'm going to present this COVID Scores on the Doors paper today in 5 short sections. First of all, introduce the paper and the concept of the scheme. Then talk a little bit about a case for a simple COVID-safe ventilation air information communication scheme. Then a little bit about the short and longer term advantages of starting a scheme like this. Fourth, just a little bit about the importance of clear communication and awareness raising more generally. And then finally, thinking about what this might look like as a certified scheme out there in the wild. And we're grateful to Dr. Alia Hughes, who's here today from Fresh Air Wales, a GP, Dr. Pamela Karantonis from Goldsmiths University of London, and Dr. Simon Williams from Swansea University for their input as we drafted this document. So obviously ventilation and air filtration, we've all become very familiar now, play a crucial role in mitigating the transmission of COVID-19. And last week's Friday briefing focused on the technical science of mechanical and natural ventilation. So the aim this week is to think about how a communication and information scheme could be designed in a way to convey technical information in a non-technical way. So this is a kind of proof of concept paper. And the proposed scheme on that basis brings together 2 familiar visual systems to maximise accessibility and try to remove language barriers. First of all, the International Energy Labelling System that we're all familiar with, and icons, which we're also very familiar with. So the scheme builds on previous proposed schemes and the kinds of infographics about COVID mitigations that have got a red, amber, green colour coding sort of system that we've seen a lot of over the last 18 months. So the process would involve something like this. This is not meant to be definitive and final, but just an idea to talk about. It would start by assessing the room, an expert technical room assessment of the space, the room, the building, and so on. And then translate this into the colour coding labelling from green to red. And then would add in icons representing the behavioural mitigations needed to use the spaces safely, and then make a product to stick on doors and labels and maybe online as well. So obviously ventilation is complex, and making decisions about the mitigations needed following the technical assessment as well will all require collaboration with ventilation and aerosol experts. But having shared drafts of the paper with a few such aspects, we're cautiously optimistic that we could get some kind of traction around this scheme. And also, it is just the case that loads of assessments have been done in loads of organisations already and communicated to users either very clearly or badly or just not at all. So this makes it even more important to have a standardised scheme that conveys the information that actually people are already providing or not providing maybe as clearly as possible. So to think a little bit about the case for a simple scheme. So first of all, obviously the COVID pandemic has revealed many problems with the UK government's public health messaging in terms of clarity, consistency, and the sort of basic enactability, so translating into behaviours. And we have talked about this before on IndySage. The main mitigations against transmission that the government's focused on, hand washing and face coverings and physical distancing, haven't been that well understood or consistently understood. And so, for example, in August this year, a YouGov poll found that people thought hand washing was more important than face coverings. So this paper focuses specifically on the issue of ventilation and fresh air as the fourth key mitigation, maybe the most important one. And scientists have recommended and called for investment in ventilation since the start of the pandemic, and earlier, of course, because it's an established public health tool. Standards for ventilation to mitigate against the spread of COVID are already well established, and we link to several of them in the paper. So to the British Occupational Hygiene Society, Royal Academy of Engineering, SAGE's Environmental Modelling Group, the Hazards Campaign, and Janet's here today, and unions. So as science about the airborne nature of COVID emerged, the basic message of fresh air and opening windows and ventilation, they started to get traction via fresh air campaigns such as ALIA's Hands, Face, Space, Replace towards the end of 2020. And a notion of ventilation was finally incorporated into the government's messaging in March 2021. Although it didn't use ALIA's nice rhyming version, we had hands, face, space, fresh air. Addressing poor ventilation is included in the UK government's autumn and winter plan, but what we don't have is a plan for transparent communication about a standard of ventilation or what is happening currently in indoor spaces, and then what people might do as a result of knowing that information. So putting the complexities of technical assessment to one side just for a minute, we also don't even have a system for conveying things like, this room has no ventilation system, or this room hasn't been assessed, we just don't know this stuff. And sometimes when assessments are done, the results are buried on organisational websites, or they're just too technical for people to understand. So while more needs to be done in terms of basic investment in producing standards and investing in infrastructure and so on, there are things that we could do now to start to develop a scheme which can then support behaviour and policy around the use of spaces. So thinking a bit about the short and longer term advantages of this kind of scheme. First of all, it could get going quite quickly since a lot of this work is being done, and while the investment in infrastructure and ventilation catches up. Such a scheme can enable other mitigations. So for example, if a room scores amber and doesn't have mechanical ventilation, or does or doesn't only has a couple of windows, or whatever it might be, then you can start to recommend that people use masks and distance from each other and so on, or time limit their use of the space, those kinds of things. A scheme would also encourage organisations to take ventilation seriously, since CEOs and employers and so on are not likely to want their buildings and spaces rated red. It would help create confidence and trust among employers and employees, businesses and clients and venue owners and users and so on. It also makes people's right to safe workplaces and other spaces explicit and tangible and transparent. And given that there is a huge diversity across rooms and buildings and spaces, the idea of this scheme also starts to raise ethical issues like consent and choice, people actually choosing to go into spaces or not. And then finally, since good ventilation, either mechanical or natural, is important for public health in general, the campaign and the system would have longevity and transferability. Okay, so the fourth section, nearly there. Awareness is obviously really important to enable and promote public health behaviours. When it comes to ventilation, a layperson with no technical expertise, just like myself, should nevertheless know the kinds of questions to ask and what to look out for regarding indoor settings. So that way people can kind of make their own risk assessments and come to a conclusion about the safety of the activity they're in. So alongside this campaign, or as a part of it, it should just enable and result in people knowing the answers to these sorts of questions. So, you know, is there ventilation in here? Does the air smell stale? Should I socially distance in here? How long should I be in here for? These kinds of questions. And while the scheme aims to provide accessible and non-technical guidance, inevitably, hopefully, the underpinning principles and the sort of technical terminology around ventilation, like ACH, air changes per hour, and other things I've started to read about lately, will become familiar over time, much like UV and SPF 15 are well established in our daily lexicons. So once in place, the scheme could be formalised. And this might be important because research on the impact of other sorts of schemes, like the food hygiene certificates that people display in businesses, shows that after mandating postings, hygiene levels improve. And also that with hygiene score posting, restaurants that earn poor scores actually improve their hygiene and then get better scores subsequently. And also that if you don't actually start to mandate posting, then basically poorly rated establishments won't post. So it's good to think about mandating and certifying this kind of scheme eventually. So what would it look like in the real world? Well, it would look like something like this, labels and doors on the windows of buildings. So something a bit like this, or maybe it would look something a bit like this, or maybe it would look something a bit like this. But overall, what we would hope for is that such a scheme would be useful, not just now during the current coronavirus pandemic, but also into the future, since fresh air and ventilation are so important for good public health. And on that note, I'm going to end with a little flying airy bird, and then I'll hand you back to Steve.
Thank you, Liz, for that excellent presentation. I found it both thought-provoking and hopeful as well. So we're now going to go to Professor Stephen Reicher, who will introduce our special guests. Stephen, over to you.
Thanks. And thanks, Liz, for such a wonderful example of communicating about how to communicate. Last week, many of you will remember we talked about the physical science of ventilation. And in a sense, the story of the pandemic is how we've come to understand more and more that transmission happens through aerosols, and therefore how a key mitigation is ventilation. Ventilation is in many ways the most important of the mitigations. Indeed, just last week, evidence came out that well-ventilated rooms can reduce the viral load by a factor of 10. So it's an extremely effective way of mitigating against infection, or rather keeping us safe. And today, then the question is, okay, we know that, the science tells us that, so what are we going to do about it? What's the way in which we can actually make sure that ventilation is taken seriously, that spaces are well ventilated, that people know how to keep themselves safe? And as you've already heard, we have three guests, a wonderful array of guests from rather different backgrounds. So we will start with Dr. Ella Hughes, who is a GP in North Wales and also played a really important role in Fresh Air Wales. We'll then move to Janet Newsham. Janet, you may remember, has joined us before when we had our Safe Workplace Charter. So in many ways, it continues that theme into the specific area on ventilation. And last, but certainly not least, Tracy Edwards, who deals with health and safety for the PCS union. So let me start with you, Ella, if I may, but I'm going to start off with a very naive question, which is often when we say, look, it's really important to take action around ventilation, for instance, the retort increasingly comes, well, why bother? Infections might be reasonably high, but they're not causing that much of a problem. The pandemic is all but over. Why bother? People ask, why bother? So from your perspective, as a GP on the front line who sees what's going on, how would you answer that question, why bother?
Hi, Steve. Thank you for the invitation today. I would go to my morning surgery because I'm in the middle of two surgeries today. And this morning I saw a child, 14 years old, who had COVID 3 weeks ago, and he's still not back at school. He's symptomatic and is finding it very difficult to regain his strength and to rejoin education again. So COVID is here. COVID will be here for some time. So it's in our communities. And I mean, people say, well, we have to live with it, with the high rates that Dr. Pagel showed before on a presentation. Well, I would dismiss the arguments that people pose and say that we need to do more than ever to try and keep the spread of the virus to as low as possible, whilst also trying to live with it in terms of letting society move on. And we now have 18 months plus of evidence, of experience of how we can really drive down the transmissions by the mitigation measures that we can introduce. And of course, ventilation being a huge key part of that.
Okay, so let me then go on to the question of how do we specifically get people to take the issue of ventilation seriously? Because you've got a lot of experience in doing that in Wales. And after the broadcast, I'm going to ask you to send me your background so we can all use that background, which is one very effective form of communication. But in your experience, I mean, how seriously do people take ventilation? How much do they understand ventilation, and how important is it to communicate around ventilation?
I think the study that was referred to before, where 65% of people think that hand washing is more important than a mask wearing, that tells a story in its own right. And I think it's very difficult to put a figure on what people think is the most important thing. But I sometimes get surprised both ways. So, for instance, I'll have somebody walking into the surgery and have put on their gel, hand sanitizer, and say, "Yeah, I've done my bit," and they've forgotten the mask in the car, as it were. And I try and educate and explain, and more than happy then to get the mask and so on. And I make a point that the window is open when I'm consulting. Then also, for instance, yesterday I saw another child coming into the surgery. I needed to examine their chest, their back, and they were wearing a sweatshirt, and I lifted the sweatshirt, and there was another sweatshirt and a few layers. And I said, "Good grief, why are you wearing so many layers?" And she said, "Well, all the windows are open in the school." So that made me smile. And of course, maybe they'd be listening to the local GP perhaps a bit more. That maybe that's happening elsewhere. But the message is coming through. But I'm a stickler. I always point out to when there are weaknesses, and it could have been done a great deal better. Behind me, I've got a Welsh play on what was the original campaign of Hands, Face, Space. Hands being the first thing that people saw. There's that primacy effect on memory. People remember the first thing and often the last thing. And I've stuck the ventilation towards the end. But we need, as the presentation by Professor Stokey demonstrated, we need a dedicated campaign to really raise the awareness of ventilation and the importance that makes to the airborne transmission. So
do you have any sense how effective your campaign has been? Any evaluation of its impact?
The honest answer is no, because I haven't been able to have time to do that. I would have loved to have been able to get proper evaluation in place. But as everyone were working so hard and on the front line, it was just impossible to get that through. But it's low level evidence. People will jokingly refer to me as Dr. Fresh Air, saying that they've heard about the message. People will say that they've been to various elements, restaurants, hotels even, where they've seen that the logo's been put up. So certain authorities have taken it up. I think Anglesey Council was the very first one back in last November. So there are examples where people have taken on the message, clearly and effectively, and then there are others that clearly they just haven't grasped it yet.
So there are examples of local councils, for instance, using your new graphics to and replacing Hands, Face, Space with Replace Hands, Face, Space.
Exactly, and actually I need to update the one behind me, because there is a newer one, which is Mask, Vaccinate and Ventilate. Because obviously since the original came out, we now have the vaccines, and I think we need to focus on those three elements and really push that message across.
And one last question. I mean, for those of us who are thinking about how to communicate and communicate clearly, and get people to take ventilation very seriously indeed, are there any key lessons from your experience that you'd want to pass on to us?
I would say what's very difficult with ventilation is the fact that it's difficult to get it visualized. Hand sanitizing very easy, and it's tactile. You'll feel the gel on your hands. Likewise, masks. Ventilation is difficult, and I think we need to give people real life examples of what interventions they can do in order to improve the ventilation. So I'll often make the comparison of somebody walking into a new room. Let's say you're attending a meeting face-to-face with colleagues. This happened to me last week, in fact, and people have a hand sanitizer when they walk into that room and apply it. It's fantastic. But how many people approach the window and open that window? That's what I did, and everyone's kind of looking at me, and then they remembered who I was. But how many people have actually opened the window when they go into new environments, or asked the waiter, the waitress, can we have the open windows, please? Because I think the ventilation could be improved. I think we need to empower people to take those actions, and for it to then become the norm, for us to be expecting people to ask those questions when we are hosting them.
Thanks very much for that. And as I say, don't forget to send us, well, perhaps the new one as well, so we can all use your logo, perhaps in our presentations. So let me move then to Janet and ask, in a sense, a naive question. Something that always confuses me about this is, I had understood that, for instance, employers and owners have a legal obligation to create safe environments. And clearly, clean air is a fundamental aspect of that. So can you tell us something about the legal obligations of both employers in workplaces and also owners of establishments in terms of hospitality and other venues?
Well, I suppose I'd start by saying that health and safety law hasn't changed throughout the pandemic. It's just the same now as it was at the beginning. And from our point of view, it should have kept people safe and stopped the transmission in our workplaces if it had been done effectively. So it's about a precautionary approach to the risks that we face and preventing workers and others in our workspaces. So anybody that comes into those workspaces or who are affected by the activity from being made ill or injured or dying from those risks, those in the workplace. So the Health and Safety at Work Act talks about ensuring the health and safety and welfare of workers and anybody else. The Management of Health and Safety at Work regs talks about employers identifying, assessing and controlling those risks in the workplaces and using a precautionary approach, so using the principles of prevention. So can you get rid of that risk? Can you stop the job and get rid of the risk? If you can't, can you substitute it by doing something else? So online teaching, online meetings is a way of substituting. If you can't do that, if you've got to continue doing face-to-face stuff, then improving engineering controls, so improving ventilation, those sorts of things, and then looking at admin controls, so less people in the space for less time, at the cleaning, the hygiene, and finally, an individual control for a residual is about masks, it's about PPE at a proper standard. So that's all in place. And on top of that, there's the specific legislation on ventilation, which talks about employers having effective and suitable provision in enclosed workplaces that to be ventilated by sufficient quantity of fresh and purified air. So that's all in place and should have protected people. Mm-hmm. But we know that the HSC entered the pandemic under-resourced, underfunded and understaffed. And so there was nobody enforcing the legislation that we have that's there to protect people.
So let me take that and see if I can put it in very simple terms. Given number one, we know that in confined spaces with large numbers of people present, then there is a high viral load, which is a risk. We know that ventilation can deal with that by reducing the load. So is it fair to say that in not ventilating such spaces, that employers are breaking the law?
Yeah, and they were before the pandemic, by the way, because when we had illnesses in workplaces before the pandemic, they spread around the workplace. And so it's never enforced to start with. And certainly, we know that that's a real risk, and the risk is about people dying in this, in these circumstances. This is a really high risk, and it hasn't been enforced. Employers haven't done it. and enforcement authorities like the HSE haven't enforced it. In fact, there's been no prosecutions of any infections for any deaths from COVID throughout the pandemic, no prosecutions.
And so, in terms of understanding why, given that what's happening is illegal, although we should stress, of course, there are some very good employers who are putting very good mitigations in place, but it's a mixed picture. I mean, given that there are such illegal acts going on every day around the country, is it just the lack of an HSE? Do you think there's leading to lack of enforcement? Why isn't it happening? Why is ventilation not being introduced, and why is the law being broken on an everyday basis?
I think there was a lot of misinformation from the beginning of the pandemic. You know, as there was a lot of good research done, and there's been lots of information about the role of ventilation as an airborne disease, you know, an aerosol disease. So that's been available for a long time. The government have really lagged behind in presenting that information in a clear way to people. And again, I think, you know, their eyes have been firmly on getting people back to work rather than making workplaces safe from the infection rates that are out there. Like, you know, so I think it's a combination of a lot of things. But certainly the government should have taken a better stance, you know, to make sure that people understood what the real risks were, and employers, you know, should have known exactly what the real. I mean, a lot of employers, as you say, have worked well with the trade unions. The trade unions have kept people safe in workplaces where they've been organised, because they've been putting pressure on employees. They're trained health and safety experts in each employment, and have done a fantastic job, you know, in trying to keep people safe in those environments. And just to say that, you know, workplaces include schools, includes hospitals, includes shops, include buses. All these places are workplaces that could have been and should have been safe for people to work in.
So I'll come on to Trade Union Voice in a moment and talk to Tracy. But if you had to say, you know, what are the three things that should be done by government and by employers in order to keep us safe, in order to make sure that spaces are properly ventilated, what would those things be?
Well, all spaces need to be risk assessed. You know, this risk assessment is a hierarchical control procedure. So each workplace needs to be assessed properly, and we need to know exactly what the ventilation is in all those workplaces. I mean, this is why this is a fantastic initiative from our point of view, because it gives a baseline of for each workspace, and then, you know, that needs to be checked. I think we talked earlier and on previous ones about certifying workplaces. Workplaces should only be open if they are actually controlling those risks of transmission, because we don't want people to be made ill. We don't want people to end up with long COVID or to die as a result of of COVID. So, you know, that needs to happen, and it needs to be enforced. So people need to be able to call the HSE and say, my employer is not doing this. You know, if they're trying to open or they're not controlling the risk, we need somebody that they can report to, and an enforcement authority that will go out there and support those workers and anybody else in those environments.
So I'm aware of time. There's so much that's interesting there, and it would be lovely to unpack in the future. But I'm afraid I'm going to have to move on to Tracy, because Tracy, I mean, you've been, you know, if you like, at the front line working on this, working with employers, in fact, working with government employers as the PCS. Do you want to tell us something about examples of good practice and bad practice you've come across in terms specifically of ventilation?
Yeah, thanks, Stephen. So, I mean, I think in terms of, employers acting on ventilation, I think that we would say generally as a union that not enough is being done, and that it's a mixed picture. We represent over 170,000 members working in the civil service departments, also in the outsourced areas, those bits that are privatised off, and the museum and culture sector. And there's no one uniform approach to ventilation, and the responses from employers on ventilation really varies depending on where you work, how well you're organised in your workplace in terms of trade union membership. And I do feel a lot of sympathy for, there's lots of health and safety managers out there who are, you know, attempting to get proper measures in place. But unfortunately, what we've seen in the civil service is that they're, you know, this was something that was developing before the pandemic, where there's been, as Janet's pointed out, a kind of deregulation, kind of changing culture, cutting red tape, all that sort of thing, where health and safety has become a box ticking exercise. And really, we've seen all that come to light really in terms of the pandemic. So it's no surprise, really, that's kind of the approach. It's very, very, very different in each different sector. If you happen to work for an outsourced company such as Serco or Bouygues or Trillium, delivering facilities management functions, mainly people of colour, mainly people who have English as their second language and who have been working throughout the pandemic, never mind raising the issue about ventilation, but if you raise issues around health and safety, with some of our members have actually been threatened with the sack. I wanted to draw two examples together. One is quite a good example of where we believe an employer has been very good. And a really good example would be to look at the Environment Agency, where at one of their huge sites up in Workington, a comprehensive report, and they brought in a heating and ventilation expert, and they compiled a really comprehensive report of all the buildings. So it was looking at all the various different HVAC systems, some of them really old, looking at whether the air is being recirculated, the type of building as well, and you could be working in a sealed building where you can't open the windows. Many modern buildings are built that way, and the measures that are needed to reduce that risk. That work was really fantastic, but I would also point out that actually that was as a result of our trade union reps, pushing for that type of detailed reporting. And it's a really good example actually where management recognise the role of appointed, trained up health and safety trade union reps and work meaningfully and jointly with us. And in terms of contrasting that approach, I wanted to draw attention, I'm sure everybody is aware of the example that is the DVLA Swansea. I think that's an important one to highlight. There's now been nearly 900 COVID cases and one fatality in that site over the past year or so. It's a shocking example, really, of poor health and safety management. And the highest cluster event, which took place in December last year, which resulted in the public health authorities having to come in and close the building down, was in the contact centre. And that's no surprise to us, given everything we know about how the airborne, how particles exist in the air. The fact that talking creates more particles, and again, that's a sealed building. PCS raised that issue, the issue of ventilation, back in November 2020. And of course, management at that time, because there was nothing coming out from government, the HSE still hadn't published their guidance. The management there were able to hide behind that lack of guidance to dismiss our concerns, and instead they insisted it was the individual actions of the workers themselves. They were breaking the rules outside, they were going partying, predominantly young workforce that continued to bring the virus into that workplace. There was no recognition that the workplace itself and the measures that they were taking had any role to play. Very patronising to the workers themselves, who, like majority of the population, complied with the rules, but no responsibility taken by that employer, and to my mind contributed towards the rise in community infection rates in South Wales. So I really welcome the presentation given today. I think that our reps on the ground have been facing quite an uphill battle, really, because, as you say, people are, reps aren't technical experts. I would also argue that a lot of the management that we are dealing with are not technical experts as well, and really employers should be looking to have technical experts in place in those workplaces. So that's a kind of couple of examples, but it really does depend, Stephen, on where you work, the type of employer, and how strong your union is.
Okay. There are so many fascinating issues there. Thank you for that. I am very aware of time, so I'm afraid we're going to have to finish at this point. I would want to stress that, as Liz said, the scheme that's been outlined in this paper is an example of what could be done. And what we hope to do is to use this as a starting point to work with others, perhaps to set up a working group to turn it into practice. So we certainly will be talking to you again. If any of our listeners is interesting or wants to contribute, please do let us know. But we do feel very strongly indeed that given what we know about the science of ventilation, it's absolutely essential now to make sure that we do something about ventilation, to make sure that spaces are safe for all workers and all customers and for the whole community. So thanks very much again to a wonderful set of contributions. And as I say, this is just the start of what we hope will be an enduring conversation.
Thank you for that really insightful discussion. So we're now going to take questions from the press and the public. So first of all, we have from Nigel Nelson from the Sunday Mirror. Nigel, are you available online? And if so, can you ask us your question, please?
Yes, Hannah, thank you very much. On a slightly different subject, with flu and COVID now threatening to come together, what is the view about whether or not flu sufferers should self-isolate in the same way as COVID sufferers do, on the basis that that would stop the NHS being overwhelmed?
Yes, Deneen, I think, has got an answer for this question.
Well, I'll make a stab at it. Hi, Nigel. Thanks for your question. I mean, I think this is a really interesting and important topic. As many know, we've not had flu for normal levels of flu for the last 20 months, and that's not only in the UK; that's around the world. But with the releasing of social distancing, more people gathering together, more people going to work, public transport and so on, there's no doubt a risk that this will resurge. And it is essential that, those who are eligible for flu vaccines get the flu vaccine, take up the flu vaccine now. It looks to be appropriate vaccine for the flu strain, the few flu strains that are circulating. But I would also hope that the heightened awareness through COVID will also allow us to be able to diagnose flu in a better way, a more extensive way, in the way that we diagnose COVID, and that therefore, we're able to control that infection better than maybe this has happened before. So I think it's an essential aspect. And of course, the risk is, as we come to winter, that with COVID continuing to circulate, as Christina has shown, and perhaps vaccine protection waning for COVID, that there is a risk for the NHS to be overwhelmed if you add flu to that. So definitely we need to take care of infection control for flu.
Thank you. And Christina?
I just wanted to add that research done at the very first wave of the pandemic, so when there was still flu around in March 2020, showed that some people got both flu and COVID at the same time, and they had worse outcomes. So I think it is just really important to urge people to get their flu vaccine if they're eligible. I had mine yesterday, and that's all.
Thank you. And Gabrielle, I believe you have something to add.
Yeah, thanks. Nigel, the WHO produces a regular report on influenza activity, and particularly we're interested in what's been going on in other parts of the world, particularly in the Far East, where often the viruses start, and levels of flu activity are below the normal levels. So it doesn't look like it's going to be a bad flu year, but that doesn't mean people should get the vaccine. They absolutely should. It will help them for the future as well. But one of the things we mustn't do is overestimate flu. Flu causes a relatively small number of deaths in this country. Winters can average between 500 to 2,000. We do have a lot of extra deaths during the winter called excess winter deaths, which are made up of not just of flu, but of pneumonia and that can be bacterial as well as viral from other causes. So there are a lot of deaths. And in fact, the UK's record of that excess winter deaths is extremely poor. And that's because it's to do with bad housing circumstances, it's to do with fuel poverty, and it's to do with reduced social services. So we do have a problem, the winter of excess death, and a lot of it is caused by circulating viruses of various sorts, but at the back of it is our need to care for elderly and vulnerable people, particularly those in poor circumstances. And that's where we should be looking to. I think the other thing I wanted to say is that we also need to pay a lot of attention to some of our other vaccines. And I've been watching how, for example, the HPV, really important that young people keep up the level of HPV vaccine to prevent particularly cervical cancer, but other cancers as well in the future. And at the moment, that's been has dropped over the last year or two. So we've got a lot of work to do across a whole load of vaccines to keep us all protected. Thank you.
Thank you. And we've also had a question in from Kevin Donnelly. Kevin, are you available?
Hello.
Hello, Kevin.
Yeah. Well, climate change, ventilation, very important, I agree, and not just because of COVID, as Janet and other people have been saying, it's important for flu and indoor pollutants in buildings and all sorts of things. And for that reason, there's building regulations for minimum air changes per hour in buildings. But at the same time, we've got a far bigger crisis than the COVID crisis coming, far more difficult to solve. And it's really urgent to reduce energy consumption in buildings. Energy goes out through the walls or windows, and you can control that with good insulation, double glazing. But it's also air changes. I've got some thoughts like natural ventilation means you've got 100 times as much ventilation in a windy day as you have in a non-windy day. So you get your COVID in the non-windy day and you'll lose your heat the other days. And buildings, if you have minimum air changes per hour, then buildings are losing energy unnecessarily when they're not occupied. So I don't suppose there's any one simple answer, but just very glad of any thoughts on reconciling the two aims, more ventilation and less heat loss, less energy consumption.
Thank you. So the balancing act between fighting climate change and fighting pandemics and trying to keep the ventilation flowing. Does Anthony Costello have any answer for this? Possibly? No?
I think Susan has her hand up, actually.
Oh, Susan.
Well, I had my hand up, not because I got an answer, but just that I've had the same question over the last year. And I understand, and I don't know if anybody here has got the expertise, otherwise we can find it, that now with new building regulations, these two things aren't necessarily in contradiction. You can have good ventilation whilst also having good heat insulation. So I think with the older buildings, yes, these things might be in contradiction and there'll have to be a balance struck. But I think with new buildings, there's many ways in which both ventilation and good heat insulation can be achieved.
Thank you. And presumably with so many old buildings in England, retrofitting them might be possible in order to balance the two. Okay, thank you for your question, Kevin. Gemma Sewell has also been in touch from Parents United. Gemma, are you available?
I am, hello. Right, hello. CBS this week, news channel, reported that homemade air purifiers are being used in enclosed spaces to remove 90% of the particles which carry COVID-19 and provide an added layer of protection against the virus. Mass production of these is happening in US universities and schools. Should we be doing the same in the UK?
Silence. Gabrielle.
Yeah, hi, great question. I've watched the innovative stuff going on in the States. I forgot the name of the boxes. It's named after the two guys or two scientists who produced the sort of first working model, taking ordinary fan heaters often and building them into boxes and putting filters, good HEPA filters around them and producing them at low cost on a mass scale. And you're quite right, in some places they've made them for all of the lecture rooms or classrooms in a college or in a university. And I think it's really innovative. I've also heard of teachers doing the same thing here. And one of the reasons they've done it is if they buy one and bring it in, they run into trouble about how it wasn't approved. It needs to be inspected and rated. But if they get the kids and work with the kids in the school, the young people in the school, to make them, well, then it's a science experiment and they can have it and use it at school. So I'm a great fan of them if you can't do better, but we really should at this stage be doing better. We should be having a system of HEPA filters available, at a reasonable price to ordinary individuals, but also they should be being installed on a mass scale, in my view, in all schools and colleges and so on, because it's the best way of dealing with it. And it also deals with, to a large extent, Kevin's last point, which was about the energy concern, about unnecessarily large heat exchange. If you can, you wouldn't have all the windows and doors open and a HEPA filter. You'd balance your needs, and it would save energy by having just one filter, a really good filter in a classroom or a lecture theatre, rather than trying to struggle with windows. And and one of the things that concerns me is that we're not seeing really good recommendations. We need consumer organizations, I think, to be looking at the available commercial models that people are having to look at now and come up with the characteristics of what makes it for a good filtration device in our circumstances, in terms of how to calculate your room size, the number of people, and balance it all together. And the same thing goes with CO2 monitors, actually, Gemma, because people are getting CO2 monitors, but they're not installing them properly. And I was in a room, teaching in a room yesterday with a CO2 monitor, which was consistently over 800, and it was installed between two windows that were half open, but not effectively. So all of this sort of stuff, it does really need the sort of codification, I think, that we're heading towards, along the lines of the scheme that Liz and her colleagues outlined at the beginning of our meeting today.
Thank you. Great question as well. We've also had Emma Goulart be in touch. Emma, are you available?
Yes, I am. Hello. Thank you for taking my question today. My question is about the COVID vaccine and children. The current advice in secondary schools is that children should not have the vaccine if they've had COVID in the previous 28 days. COVID's very rife in all the secondary schools near me, with lots of children going off sick every day. And we're told that a lot of children can have COVID asymptomatically, and lateral flow tests have a problem with false negatives. So my question is it safe for children to have the vaccine if they could have had COVID asymptomatically in the previous 28 days? Thank you.
Thank you. Very relevant question, particularly with Christina's data that was being shown earlier. So is there anyone who might be available to help answer that question?
One for Helen.
One for Helen. Helen's been volunteered.
I think it's a really interesting question. And I suppose the question is, are you going to get harm from having the vaccine when you've just had COVID? Not as far as we know, I think, is the answer. And there have been some suggestions that we should make that gap between saying you've had symptomatic COVID and when you can have a vaccine smaller than 28 days, because at the moment we're cutting out a whole load of children who are then missing the date when the vaccine's available. And I don't know on what data that actual 28 days was originally based. Maybe some of my colleagues can help me with that. I have not read anywhere of people being made more ill by having the vaccine, having had COVID before. In fact, there's some really interesting stuff that some people who've got long COVID have a vaccine and actually suddenly feel very much better. And their response to vaccine somehow helps them fight off the lingering effects of COVID. So I personally wouldn't be at all worried about children who had an asymptomatic infection then being vaccinated, and that they might have some bad reaction to the vaccine. I've not heard of that at all. I think it's very unlikely. I think there is an interesting question about whether that 28-day rule does need to be quite that long. And I'd be really interested to know what my other colleagues feel about that.
I know that in Australia, it previously had been advised that there should be 6 months between somebody testing positively for COVID and then getting the vaccine. But I think that policy was actually largely due to the fact that the rollout in Australia was so slow and the availability of the vaccine was so small that they wanted to prioritise people that hadn't been affected so far. Hopefully that helps reassure and answer some of your questions. We're actually going to run out of time quite soon, so we've just got time for 2 more questions. So Sophie Sweatman, if you're available, if you could ask your question as quickly as possible.
Yeah, I'm here. Yeah, it's Sweetman. Sweetman. It's spelled Sweatman though. So my question is, have public health messages since March 2020 been counterproductive in terms of nutrition and outdoor activity, lifestyle changes, and looking after our immune system due to lockdown restrictions led to a widespread health crisis in the UK? Looking a bit bemused. This is basically the abrupt changes to daily routines and staying indoors, lack of exercise, people in polluted city centres not being able to get away from pollution and all sorts of things, rather than just closing indoor social spaces and keeping windows open.
Thank you, good point. And Gabrielle is on hand to help.
Well, it is an interesting question, Sophie, but let me start with, has it created a public health crisis? We were in a public health crisis before the pandemic hit because we know that life expectancy improvement had stalled. And for some groups in society, particularly women, particularly in the most deprived communities, it was going down. And those changes started around 2012. And had continued. And really almost a unique situation we were in with that deterioration. That was accompanied by a whole lot of other stuff. Falling in vaccination rates, increase in infant mortality, increase in drug-related deaths, increases in sexually transmitted diseases. A whole string of public health things were going wrong. And the public health system was going wrong and was becoming really, really ineffective and marginalised, with large amounts of money taken out of it, particularly taken in cuts to local authority public health grants. So we were in this bad position. I think we'll have to wait and look back on the whole periods, particularly periods of social restriction, and see what the balance of harm and benefit has been. Some of it has been good. Air pollution actually dropped quite substantially because traffic dropped substantially. A lot of people went out and took exercise who maybe wouldn't have taken so much exercise. And one of the good things that I think we rediscovered the importance of public spaces, of being able to find spaces, and also maybe, just finish on this, maybe all the attention that we're trying to focus and help people focus on in terms of ventilation and purified air and fresh air will also mean that we will take more of an interest in air pollution. We will take more of an interest in the green environment. We will take more of an interest in, certainly, if we come out of this pandemic with an increased focus on what's healthy, that would be a great thing.
Yeah.
Thank you, Gabrielle. And I'd like to echo some of his positive sentiment there and just say that paradoxically, during enforced isolation measures, there's been an increase in community spirits, with neighbours helping each other out and looking out for each other in ways that possibly they weren't doing so before. Okay, so we've got time for one last question, this one from Alison Copeland.
Hi, yes. Hi,
Hello,
Hi. So yeah, my question, thank you very much for taking it, is that we've currently got a COVID positivity rate, in other words, the amount of testing that's coming back positive at 4%, which has gone up slightly since I asked the question yesterday when it was 3.2. But our numbers are rising, and my understanding of positivity rates is below 5. It should either be that the pandemic is under control or that we're not testing enough. And so I'm assuming it's the latter, given our numbers are going up. I would appreciate people's thoughts on it.
Thank you. Great question. I'm going to hand that over to Christina. Yes, she's got a hand up now. So
yeah. So where are you getting your positivity rates from?
From the One World Data site.
Yeah, I don't think that's the best place to get it from. So if you look at our dashboard, in England, positivity rates have been about between 7 and 9% for the last few months. In Scotland, they're over 5%. And I think they are in Northern Ireland and Wales as well. I think our world in data doesn't kind of adequately account for the fact that some people take more than one test. They probably just get taken off. So we are over that 5% threshold. And it is also just the guideline that the WHO uses that says, you know, you should be trying to do a lot of testing to pick up as many infections as possible. And so that it's not that under 5% everything's fine and over 5% it isn't. But it just kind of gives you an idea of, you know, are you doing appropriate levels of testing? And at the moment, we do have positivity rates higher than that. And so we probably do need to pick up more tests, pick up more cases.
Okay, thank you.
Thank you so much. Okay, well, I think we're going to have to wrap up now. Thank you so much to our special guests, Tracy Edwards, Janet Newsham and Ela Hughes, and to our scientists for joining the discussion and answering your questions. All of our scientists are volunteers, and they're here because they believe that as a society, we need open communication between scientists and the public, especially during a pandemic when we're all making important decisions and need to be armed with information. All of Independent Sage's reports are available on their website, along with biographies of all the scientists. And you can follow Independent Sage on Twitter and on Instagram. Thank you to everybody for watching, whether you're with us live or catching up later. And thank you for the questions as well. Please do keep those coming in. So we'll be back again, same time, same place, next Friday. Goodbye.
Thank you, Hannah. Bye.